everyone. My name is Natalie Ferriozzi, and I am a graduate student in the Nutrition and Dietetics Masters of Science and Dietetic Internship program at Eastern Illinois University. Today, I will be presenting my systematic review that focuses on the coexistence of disordered eating behaviors and depression in type 1 diabetics. This presentation is for the class Nutrition 5600, and I hope you enjoy. Here's a quick overview of the presentation. I will begin with the introduction. In this section, we will go over some important terms to know for the presentation, as well as some statistics regarding the status of depression and disordered eating behaviors, or DEB, in different populations. We will then cover the purpose of this presentation. Then I will go over the methods, or steps I took to find my 10 primary articles. I will discuss my inclusion and exclusion criteria, my PRISMA diagram, and a chart that documents the important aspects of each article or study. We will then synthesize the results from these articles and discuss why and how often the results occurred. Finally, the discussion will cover the strengths and weaknesses of this systematic review, as well as some interesting trends that help determine the future implications. In the conclusion section will be a statement answering my research question, do disordered eating behaviors and depression coexist in type 1 diabetics? Type 1 diabetes is a chronic autoimmune disease where the pancreas makes a small amount of insulin or none at all. Insulin is a hormone that causes glucose, or sugar, to enter the cells where the body can then use it for energy. Chronic simply means it's happening for a long time, or it's constantly reoccurring. And because diabetes is an autoimmune disease, that means that antibodies are being produced against substances that are normally occurring in the body. In other words, the body starts attacking perfectly functioning cells, organs, and systems. In this case, beta cells are being attacked in the pancreas, which is causing it to not function properly. This was previously called insulin-dependent or juvenile diabetes because it is typically diagnosed in children, teens, and young adults. However, it can develop at any age. And concrete prevention measures or reasons for developing type 1 diabetes are unknown to this day. If the cells cannot bring in glucose, a buildup of glucose in the bloodstream happens, and it's called high blood sugar or hyperglycemia. Long periods of hyperglycemia is damaging to the body, specifically the kidneys, heart, blood vessels, eyes, and nerves. Symptoms of hyperglycemia include frequent urination, increased thirst, blurred vision, fatigue, headache, nausea and vomiting, and in serious cases, diabetic ketoacidosis leading to coma. Diabetes affects 10% of individuals globally, which is about 463 million, and 5 to 10% of those individuals have type 1 diabetes. Individuals diagnosed with this, including their caregivers dependent on the age, are required to learn how to count carbs, eat balanced meals, understand the signs, symptoms, and treatments of both hyper and hypoglycemia, prick their fingers for blood glucose tests multiple times a day or wear a continuous glucose monitor, and take insulin shots or wear an insulin pump. In addition to this, staying in close contact with the healthcare team is essential. Disordered eating behaviors, or DEB, is a broad term that includes dieting, binge eating, and a range of compensatory and purging behaviors such as self-induced vomiting, abuse of laxatives, diuretics, or diet pills, and excessive exercise. This can also be viewed as a DEB spectrum. Whereas an eating disorder, or an ED, is restricted or chaotic food intake, a morbid preoccupation with food, weight, and shape, and a distorted body image. Common eating disorders are anorexia nervosa, bulimia nervosa, binge eating disorder, other specified eating disorders, and unspecified eating disorders. If we're looking at this as a spectrum, The far left point would be a subclinical disordered eating behavior, and the far right point would be a diagnosed eating disorder. Subclinical simply means that the symptoms are not yet observable. An example of this would be if an individual has thoughts about performing the DEB activities. This research does include eating disorders because it is a part of that DEB spectrum, which we'll discuss more in the method section. To put this in perspective, according to the National Eating Disorder Association, 30 million people, both males and females, have eating disorders in the United States. A 2019 systematic review in the American Journal of Clinical Nutrition also stated that 17%, or 1.275 billion of the global population, had an eating disorder between the years of 2000 and 2018. The global prevalence of DEBs was a less common statistic. However, research indicates that DEBs are included in the ED stats that I just mentioned. Some comorbidities of DEBs are major depressive disorder, PTSD, OCD, sexual dysfunction, suicidal ideations, extreme weight loss or gain, cardiac irregularities, hypoglycemia, and electrolyte imbalances. So if we're applying this information to the type 1 diabetic population, we can see why this may be of concern. The prevalence of DEBs in type 1 diabetics is actually 2 to 3 times higher than the general population. So much so that a specific type 1 diabetes ED has been discovered recently. This is called insulin omission, which is when an individual restricts insulin for weight control. Depression is a mood disorder that causes a persistent feeling of sadness and loss of interest. It affects how you feel, think, and behave, and can lead to a variety of emotional and physical problems, such as the inability to feel pleasure, disrupted sleeping and eating patterns, worthlessness, and suicidal ideations. This can also be referred to as clinical depression and or major depressive disorder. Depressive symptoms versus a clinical diagnosis of depression or major depressive disorder are different and may cause some variance in the findings for this population. However, in this systematic review, any indication of depression was included in the data. The World Health Organization found that globally 264 million individuals of a variety of ages suffer from depression. The prevalence of depression in type 1 diabetic populations is actually 4 times higher than the general population. So risk factors associated with developing depression as a type 1 diabetic include the stressful management requirements, health problems, and a weakened immune system, coping mechanisms such as unhealthy eating, a lack of exercise, or even smoking, and the interference with clear thoughts and task performance. Each of these items can exacerbate the onset of depression and worsen type 1 diabetes health complications. There is evidence to show that symptoms of depression can also mimic the symptoms of uncontrolled type 1 diabetes, which can prolong the diagnosis of depression. Mood disorders have been found to be the most common psychiatric comorbidity in eating disorder populations. However, there's limited research on the coexistence of the two in a type 1 diabetic population. A new term called diabetes distress is similar to depression, but this is an emotional state where people feel stress, guilt, or denial that arises from living with the burden of managing their diabetes. There is recent research looking into the difference between the two and just how to better educate healthcare professionals on the detection of these disorders. An article on diabetes distress and associated factors found that high diabetes distress is associated with perfectionism, high dietary restraint, shape or weight concerns, and higher depression scores as well. The study developed a diabetes distress screening tool and concluded that the use of these types of questionnaires can help to identify those who may need additional screening for depression, DEBs, or additional education and support. These are some of the diagnostic criteria scales or questionnaires that are commonly used in screening and diagnosing DEB and depression. Most of these were used in my 10 primary articles, and I will be explaining a few more along with my research data chart. But the column on the left is eating disorder questionnaires, and the column on the right are depression questionnaires. So I am a walking example of this research question. I've been a type 1 diabetic for almost 20 years, and I've dealt with just about every challenge in the book. Within the last year, I was diagnosed with moderate to severe major depressive disorder, and I was put on medication. I experienced weight gain, changes in my sleeping and eating patterns, and a lack of motivation to take care of myself. When I was a teenager, I was also placed on the DEB spectrum, and I had several sessions with a registered dietitian and a certified diabetes educator. My endocrinologist screens for both of these disorders at almost every visit, which is about 6 to 8 months apart, but that's not consistent or possible in all healthcare systems. I also wondered how I, as a nutrition professional, could contribute to nutrition research and prompt other practitioners to develop or improve practices for managing these globally prevalent disorders. This research is definitely a starting point for the awareness of this incidence. The purpose of this presentation is to summarize current scientific research that assesses the incidence of disordered eating behaviors and depression coexisting in type 1 diabetics. It is also to assist dietetic professionals in their awareness of the symptoms and occurrences of DEB and depression in this population. I will now discuss the methods I took to find my 10 primary research articles. I used 5 electronic databases through the Eastern Illinois University's library. These were Academic Search Complete, CINAHL, PsycInfo, PubMed, and Google Scholar. I used the first 4 through EIU's EBSCOhost portal because I had used EBSCOhost during high school as well as undergrad, and I was familiar with its functions. The key terms I searched were combinations of disordered eating behaviors or eating disorders, depression or major depressive disorder, and type 1 diabetes mellitus or T1DM. If you're familiar with the functions of EBSCOhost, I was able to combine all of those terms in each search category, which is where my grand total number of articles came from. I set the dates for 2008 to 2020 to allow myself some wiggle room within the last 10 years inclusion criteria, which I will discuss in the next slides. EBSCOhost also has the option of selecting peer-reviewed journals and articles. If I selected articles from Google Scholar, I simply researched those journals to ensure all of my 10 primary articles were from peer-reviewed sources. Here are the list of my inclusion and exclusion criteria that all of the primary articles had to meet. Each article had to be peer-reviewed and published within the last 10 years. There also needed to be an examination of the prevalence of DEB or eating disorder diagnoses, as well as depression and type 1 diabetes. Because of this, one of my primary articles is from 1995. I had a difficulty finding recent primary research on this coexistence. There were a lot of secondary analyses, but not primary. But the quality of this article was excellent, so I decided to put it in. I did not require a specific diagnosis date or an amount of years the individual had type 1 diabetes because I wanted this to be a starting point for deeper research on this topic. The research had to be on human subjects, and the sample size needed to be 100 or more individuals for the initial recruitment. I attempted to narrow down my age range, but there was not enough primary research for one specific age range. Also, because type 1 diabetes is a chronic disease, I found it important to cover different age ranges. I wanted to include both males and females to see if there were trends for gender, and I also wanted to include various countries because these disorders and disease have a global impact. All systematic and literature reviews were excluded because they are not primary research. Articles that were published before 2010 were excluded, except for that one from 1995. And articles that did not have a p-value or a statistical significance measure for both DEB and depression were also excluded. There was a plethora of research on type 1 diabetes in either depression or DEB, but there were few combining the two, which prompts a need for this systematic review. We will now move on to my PRISMA diagram. PRISMA is an evidence-based set of requirements used when reporting for systematic reviews and meta-analyses. The purpose of using a PRISMA diagram is just so future researchers can have an understanding of where and how I found my primary articles. I had initially gone into this topic with the hope of focusing on only adolescent type 1 diabetics, but there wasn't enough primary research. After doing some preliminary research with the databases, I decided my inclusion criteria would have a wide age range and include various countries because, as mentioned, these disorders are globally prevalent and type 1 diabetes is chronic. My search terms are listed on the left, and in both the EBSCOhost databases and Google Scholar, I used all or combinations of these terms. I created a PRISMA diagram consisting of the results from including all of the terms. In the EBSCOhost databases, I yielded 343 results after including my time frame of 2008 to 2020 and clicking the box for peer-reviewed journals. In the Google Scholar database, I yielded 16,773 results after including the time frame of 2008 to 2020. This gave me a total of 17,116 results. These numbers may be variable because this is a representation of using all of the terms at once. After exporting these results to Zotero and removing duplicates, I had 9,450 results from all of the databases. After scrolling through the pages, I screened the abstracts of about 50 articles and excluded 20 based on the information from the abstract and my exclusion criteria. I had direct access to 30 articles, which I screened more in depth, and then removed 6 because of the date, 3 because Eastern could not get access to them, 2 because they didn't have a p-value for depression, and 4 because they were systematic reviews. This left me with 15 articles to read fully, and based on quality assessments, I narrowed it down to 10 primary articles. Some of these 10 primary articles were found through examining the references of other primary articles or systematic reviews. All 10 are quantitative because both DEB and depression scores were able to be measured through the use of scales and numbers. However, it could be argued that they are mixed methods because some articles dove into the reasons behind developing depression and DEB, which was not an active part of my research. The next 3 slides will show a breakdown of my 10 primary articles through this research data sheet that I created. This method helped organize the data and make it easier to compare the studies. From each article, I extracted the author, year and country, duration and design, where the participants were recruited from, how many participants there were, the age and gender of the participants, evaluation measurements, and if there was an existence of depression, DEB, and both. The starred items are self-reported measures, and the red items are statistically significant values. While reviewing each article, I also assess the quality and the purpose of each study. Those details will not be shown, but referred to throughout the presentation. Among these 4 articles, the age range is 13 to 79 years and is a mixture of both male and female participants. In the last 3 columns, you will see that each answer looks a little different. While this will be touched on in the limitations, right now an explanation is necessary. Each study measured their values slightly different through questionnaires or statistical tests. Some used both. Remember, I was simply looking for the coexistence of DEB and depression in type 1 diabetics. This left a lot of wiggle room. Some studies provided statistical tests on the coexistence, while some simply made a statement about the relationship, if any. For example, the study by Bach found through statistical analysis, as indicated in red, that 27% of females had coexisting eating disorders and moderate depression severity. In the next slides, you'll see whether a p-value or a percentage is apparent if statistical tests were used, and a yes or no if a statement was used. The age range for this set of articles is 10 to 26 years and includes both male and female participants. Each study used similar but different evaluation criteria. One major reason for this is because of the range of countries included in the systematic review. The 6th column listed the questionnaires, evaluations, and tests that were related to DEB, depression, and type 1 diabetes. A common screening tool for depression was the CDI, or the Children's Depression Inventory, which can be found in Articles 1, 6, and 10. A common screening tool for DEB was the DEPSR, or the Diabetes Eating Problems Survey, which is a specific tool for individuals with diabetes and can be found in Articles 2, 4, and 10. DSM-IV, V, or 5 criteria focuses on the significant behavioral or psychological patterns that occurs clinically and leads to a diagnosis. Screening tools for DEB and depression are developed with that criteria in mind usually. Demographic, health, and biochemical data was either self-reported or obtained through clinical testing. This is where most of the information on type 1 diabetes management, diagnosis, and history is obtained. Each of the screening tools listed for both DEB and depression are Likert-based scales that determine the frequency or occurrences of symptoms and/or the diagnosis. For example, in the article by Powers et al., the EDEQ, or Eating Disorder Examination Questionnaire, is a 41-item self-report questionnaire that assessed the presence and frequency of ED behaviors, thoughts, and feelings about the body over a course of 28 days. It is important to note that for studies 1, 4, 6, 9, and 10, the parents had to give consent for their children to participate, and they also supplied the self-reported information. The participants who completed the actual questionnaires were the children. For the quality assessment, none of these articles stated whether or not the parents were able to assist them in answering the questionnaires. This could be problematic because if the child is in a state of denial or lack of care or is simply unsure of the answer, results could have been skewed. The participants were recruited from outpatient diabetes care facilities in 7 of the primary articles. The other recruitment styles were through other studies, universities, Facebook groups, forums, and community organizations. The age range for this last set of articles is 13 to 38 and includes both male and female participants. The study design for all 10 primary articles were mainly cross-sectional designs or case control designs. I did have one longitudinal study. Cross-sectional studies are observational and cannot determine causation. Case control studies have a comparative nature, and in 5, 6, 7, and 9, type 1 diabetic individuals were compared to individuals without diabetes in regards to DEB, depression, and other measures such as BMI, snacking tendencies, and management techniques. The lack of longitudinal studies was disappointing, being that it offers the opportunity to examine these disorders over a long period of time. It would have been interesting to know if the participants had received either nutrition education or psychological interventions pertaining to eating disorders previous to the questionnaires. In the article by Powers et al. On the previous slide, the participants had already been diagnosed with an ED and were being compared to non-type 1 diabetic individuals who had also been diagnosed with an ED. A deeper look into the success of these types of education sessions and interventions would be interesting for future research. It also would have been interesting to note that in cases of past experiences with symptoms of depression, if the individual had ever taken medication for that or was currently on it. The articles used vague terms like not on other medications for exclusion criteria. These types of medications can lead to weight gain, which may have an impact on the results. Studies 8 and 10 looked into insulin omission behaviors, which is that eating disorder that I talked about in the first slides. It's a part of the DEB spectrum and is a newer eating disorder specific to the type 1 diabetes population. As you can see in both of these studies, depression values were also significant. 70% of the primary articles had p-values or percentages indicating the degree of coexistence. All 10 articles had p-values for both DEB and depression separately, which was a part of the inclusion criteria. Only one article had less than 100 participants. This is the article by Vila et al. On the screen. The participant count was 98, which was close enough to 100. I decided to send this article to the class because I felt it gave a nearly perfect representation of my research topic and inclusion criteria. For this cross-sectional study, 282 adults with type 1 diabetes, aged 18 to 79, participated in the study after being recruited from an outpatient adult diabetes clinic in Toronto, Canada. 113 were males, and 169 were females, so the study was almost evenly split between genders. They were required to complete the Diabetes Eating Problem Survey, the Hospital Anxiety and Depression Scale, as well as supply clinical data through the Norwegian Quality Improvement Laboratory examinations. These measures included hemoglobin A1C, type 1 diabetes onset, and type 1 diabetes treatment and management. Weight and height were self-reported and used to calculate BMI values. There was no specific exclusion criteria listed anywhere in the article, which is actually part of why I chose it. Type 1 diabetes is a multifaceted disease, and this was a good starting point article before narrowing down the population further. The results concluded that both males and females had significant values for depression, DEB, and the coexistence of both. However, some important notes to discuss are that 56% used insulin pens and 43% used insulin pumps, which just shows that the management styles were different. These were patients from one clinic, which kind of minimizes the population a little bit, and the cutoff score for moderate to severe depression was 11, when in other studies it was 8, so that could create some variance when writing a systematic review with this article. Anxiety scores were overall significantly higher than depression scores individually and when combined with DEB. Finally, depression, DEB, and coexistence scores were consistently higher for females. Small variances and interesting trends like these are important to note when writing a systematic review. More trends applicatory to this review will be discussed towards the end of the presentation. All right, for the results, we have 10 out of 10 of the primary articles showing a coexistence between DEB and depression in their type 1 participants. This means that in 10 studies of 100 or more type 1 diabetic individuals, DEB and depression were typically occurring at the same time. However, shouldn't we assume this? As we all know, the goal of research is not to assume, but to find patterns. DEB and depression were already established as heightened in this presentation. But what we have discovered from the systematic review is that there may be a relationship between the two that goes deeper than them just occurring at the same time. As a reminder, we cannot imply that type 1 diabetes causes the coexistence of DEB and depression, but we can imply that they do commonly exist at the same time. A secondary result of this research found that in 60% of articles, not including the all-female studies, coexistence was higher in females than in males. Another secondary finding said that 30% of the primary articles showed a coexistence of DEB and depression occurring more frequently in type 1 populations than in the general populations. So if you remember the stats at the beginning of the presentation that claimed that DEB was 2 to 3 times higher in type 1s and depression was 4 times higher in type 1s, now we can claim that 30% of the primary articles in this systematic review found that coexistence is more common in type 1s than the general population. In 60% of the primary articles, moderate to severe depression was experienced either currently or in the past. In the other 4 articles, depressive symptoms were experienced either currently or in the past. It is important to note that any depressive symptoms were included as an existence of depression. The degrees of severity may vary. When compiling all of the information from these 10 primary articles, it was found that 1,329 type 1 diabetic individuals were recruited into these studies. 1,285 actually completed the studies and all the requirements associated. 54% of that were females, and 46% were males, so it was pretty evenly split. 3 studies were female-focused or consisted of majority female participants, and 2 studies did not give any information on how many males or females participated out of the whole and were excluded from the gender calculations. The overall age range for all of the studies was 10 to 79 years. 5 of the studies focused on adolescents, which was ages 10 to 19. 4 of the studies focused on adults, which were ages 18 to 40, and 1 study focused on early adult, middle adult, and older adult age ranges. Early adult is 18 to 30, middle adult is 30 to 40, and older adult is 40 to 80. This last study was the one that I sent out to the class that we reviewed a few slides ago. As mentioned, DEB, depression, and type 1 diabetes are globally prevalent, and I found it important to include research from various countries because of that. I found research from Canada, Norway, Germany, the United Kingdom, the US, Australia, Turkey, and some undisclosed areas of Europe. So what do my findings mean, and what could influence or change them? As a reminder, the purpose of my presentation was to assess the incidence of DEB and depression coexisting in type 1 diabetics. Among all 10 of my research articles, it was suggested that type 1 diabetics are at risk for experiencing both DEB and depression at the same time. As mentioned, the severity of depression varied with these studies. Also, the cutoff scores for both DEB and depression scales varied among all of the studies, meaning that the consistency of the results may be lenient. Coexistence was higher in type 1 diabetic females in 60% of the studies of male and female participants. The results were also significant in the 3 studies with majority female participants. The female studies consisted of adolescent and early adult participants. Supporting research indicated that the onset of depression and DEB was often in adolescence to early adulthood. This research noted similar findings, but limited statistical tests were done on the topic. It is important to keep in mind that 50% of the articles covered these periods of age. A secondary article on the prediction of the onset of DEB in adolescent girls found that in age periods of adolescence, depression was significantly associated with the onset of DEB at a p-value of 0.0001. Only one comparative study showed higher values of DEB and depression coexistence for individuals without type 1 diabetes. The authors discussed that may have been triggered by the early to middle adult age of the participants, the use of insulin pumps, the time frame of their diagnosis, and much more. Insulin pumps were mentioned in 20% of the studies, indicating that the use of them showed improved DEB and depression scores. More research is needed on these topics. So the research suggests that the incidence of disordered eating behaviors and depression are coexistent in type 1 diabetics and may have an association with age, gender, and diabetes management styles. In summary, the purpose of this presentation was to summarize current scientific research that assesses the incidence of disordered eating behaviors and depression coexisting in type 1 diabetics. I felt this was important because I'm a walking example of this research topic. I also wanted to contribute to nutrition research to assist dietetic professionals in their awareness of the symptoms and occurrences of DEB and depression in type 1 diabetes. To locate my articles, I used EBSCOhost through Eastern Illinois University's library, where I accessed Academic Search Complete, PsycInfo, PubMed, and CINAHL. I also used Google Scholar and examined reference lists of primary, secondary, and tertiary sources. I used the Prisma diagram and the research data chart to help keep myself organized throughout. The findings from 100% of the primary articles indicate that DEB and depression do coexist in type 1 diabetics. This led to the conclusion that these two disorders are coexistent in type 1 diabetes and may have an association with age, gender, and diabetes management styles. More current and expanded research is needed on this subject. Next, I will list the limitations and strengths of this systematic review. Not all of my articles were from 2010 or later. One article was from 1995, but was an excellent study that provided additional information on obese type 1 diabetics. As mentioned, I had a difficult time finding primary articles that included both DEB and depression, and I decided to go with this one over a 2008 article because I valued its quality. Another limitation is that I had a wide age range, which made it more difficult to compare results. However, from this limitation, I was able to discover trends within the potential onset of these disorders. The lack of studies done on older adult to geriatric populations is problematic because it leaves a large portion of this population out of the compiled data. The different study methods made it harder to compare the results as well. With the observational nature of cross-sectional, the comparing nature of the case control, and the prolonged nature of the longitudinal, this gave almost too much information. More longitudinal studies would have been beneficial because of the chronic nature of type 1 diabetes. There were more female subjects, which again may leave out a small important portion of this population, which are the males. The research was difficult to follow because many of the primary articles tested for associations with weight, diagnosis, etc. There were not only variables of DEB and depression. I had to go in and specifically find the values relating to my two topics and make sure the statistics were accurate. Lastly, I did not specify the severity of depressive symptoms or if I wanted a clinical diagnosis of major depressive disorder. This would have helped narrow down the research a bit. Strengths of this systematic review include the use of PRISMA, which will assist future researchers in expanding upon this baseline topic. Another strength was the inclusive nature of the study. By being able to expand the parameters, several important trends within this topic were found. I had 6 primary articles published within the last 5 years, which helps keep this topic up to date. And my use of different countries and large sample sizes help give respect to the global incidences and rates of these disorders. In addition to the interesting trends I've already mentioned in previous slides, I also wanted to note on a few more. In 20% of my primary articles, type 1 diabetics who were transitioning to or already on an insulin pump had lower DEB and depression scores. And in 20 to 30% of the primary articles, anxiety scores were higher than depression, which was interesting. Which leads to some future research ideas. We could go into the idea of snacking, which would be great for dietetic professionals to look into with research. We could also dive further into insulin omission. There was a great lack of research on males and the geriatric type 1 diabetic population, so those gaps could be filled as well. We also could look into the effectiveness of education sessions or interventions for DEB and depression individually. If they develop types of interventions combining the two, that would be wonderful, and we could also assess the effectiveness of that. As mentioned, diabetes-specific emotional distress or diabetes distress is a hot topic right now and often gets confused with depression, so more research on that seems to be needed. Just anything a little bit more specific than what this was. Anything like looking at values of A1C or metabolic control would narrow down this topic and help us get more information on how to manage, educate on, and screen for these disorders in type 1 diabetic populations. So what does all of this mean for future nutrition professionals? Well, depending on the DEB or ED, RDNs play a huge role in the management and therapies of individuals suffering from those disorders. Also, dietary behaviors associated with depression might include binge eating, consumption of processed foods, or even just an overall disruption of sleeping and eating patterns, which RDNs will also play an active role in improving for individuals. If we are more aware of the signs and symptoms of these two disorders, we may be the first one to mention even screening the individual. A common path for RDNs is to work with diabetes and become a certified diabetes educator, or a CDE, which I mentioned earlier, where we could be working up close and personal with this population at risk for this incidence of coexistence. The more we can educate ourselves and advocate for better screening procedures, the more we can minimize the occurrences of these. Lastly, by paying attention to the types of questionnaires the healthcare field uses, we can prompt practitioners to improve the quality of them and learn how to communicate with the individuals in a way that will promote honest answers.